And hi, I'm Kelsea Green, paediatric speech pathologist, orofacial myologist, and myomology parent advisor and clinical advisor. Today's live is actually all about how does oral dysfunction actually occur. But I'm joined today by the wonderful Dr Samantha Anne, a neurodevelopmental chiropractor with over 17 years experience. Her work centres around helping kids thrive through gentle, evidence-informed chiropractic with cranial growth support and holistic care. She's also a myomology clinical advisor and just brings so much valuable perspective to these conversations. So welcome, Sam, and thank you. But before we dive into sort of the main things we're wanting to discuss today, I thought you could share a little bit your work as a chiropractor and how you support children with oral development.
Okay. Thank you so much for having me on, Kelsea. And just bear with me today. I've having my own little bit of a health expression, so my voice is not what it normally is. So I came into this line of chiropractic from my own lived experiences of having trouble with my airway as a child and seeing a chiropractor as an adolescent, and it made a phenomenal difference. And then with having had my own children who had some oral dysfunction, again, I was like, I need to learn more about this, which then inspired me to go on and learn a lot more. So that's sort of 17 years down the track. Here I am. And I guess my work is about understanding a child's trajectory, like their growth trajectory, and just seeing what we can just adjust a little bit in order to be able to get them on that correct trajectory. So it's not about we're fixing anything. It's all about we're removing interference to that child developing as optimally as possible. So in terms of what I do as a chiropractor, I'll be looking at like the whole picture. So I'm not just looking at whether or not that child's got any sort of oral dysfunction. I'm looking at that whole neurodevelopmental spectrum. And it's about understanding how the brain develops and what sort of inputs that we can give, whether or not it's the work that I do as a chiropractor. But actually the majority of the work is how I support parents with what they do at home, and giving them lots of guidance as to, how to make sure that we've got that child on that trajectory. So it's very different to, say, my adult clients that I would see, how we work with along the spectrum of childhood. We're very much working with the body and its developmental stage that we have in front of us. So how I work with a 2-day-old is going to be very different to how I'm working with an adolescent, and the type of things that I'm assessing, what I'm looking for, and what inputs I'm going to be giving, and how that is going to change that child's trajectory. So it's very unique. It's quite nichey. I've managed to somehow niche myself in the chiropractic world and what I do. And again, it's just a lot of it's from my own lived experience of myself, my children, and just what ended up kind of landing in front of me clinically. And I would get some really tricky cases, and I'd be like, I need to know more. I need to know more about this to be able to show up and help my community.
Yes. You were so passionate about it, and we're very lucky to have you here in Newcastle. I'm very excited that you've been around. And working jointly with some clients has just been like a game changer in my world too. So very excited to have you on today, and thank you for sharing a bit about your work. And yes, that why behind what we do, it always comes from somewhere and drives that passion. When we're talking about oral development in these little ones, we often, and I know you often present about the analogy of being like a tent and tent ropes. So from your perspective, how does oral dysfunction actually develop? So what's happening with the muscles and bones and the habits that throw that tent out of balance? You might explain the analogy a little bit too.
Yeah, absolutely. So if you can imagine like the tent, like when we put up a tent, we've got these like really strong poles that are holding this sort of, fabric into a shape, right? And we can't just put the poles up and kind of expect the fabric to hold the shape. It's not going to do that. We're going to require guide ropes on that, and that's going to put tension in specific areas that's going to maintain the shape of that tent. So if we've got, say we've got one guide rope done up really, really tightly, but the other one's quite loose, it distorts the shape of that tent. If we haven't got them done up very tightly at all, there's just no input, there's no pull, there's no tension on those guide ropes. The tent sort of collapses in and it's not holding its integrity. So if we think about the craniofacial structures, and I talk to parents about, the roof of the mouth is the floor of the nose, and I show them pictures of an airway, and I show them how we need to have that nasopharynx nice and open. I'm like, that's your tent. That's your tent. We want that structure to be nice and broad and holding the good tension to maintain its shape. If we've got distortions, that's going to change the integrity of that. If we don't have the tension on, we've got low tone, that's going to change the integrity of that. And how that sort of dysfunction occurs, whether it's an asymmetry, whether it's a low tone, happens very, very early on. So from about week 7 in utero, we start to lay down the cranial base, which is, this is a good thing about coming into the office. So this is the base of the skull here. This is the cranial base. And so that starts to lay down in about week 7 in utero. It's very early on, and it needs a lot of bioavailability of different nutrients. And some of those we've been deficient in them for like 7 or 8 generations. So it's really difficult these days, and this is why we've sort of see more commonly that we've got that underdevelopment in narrow airways, is because this has been happening over generations and generations. It's not just, a new thing. It's that we're becoming more aware of it.
Yeah.
When a baby's oral system starts developing in utero, they start that early tongue movement and swallowing at around about 18 weeks, give or take. Actually, a lot earlier, they've noticed movement. And what's driving that is the neurology. So we've got the brain stem. It's the very kind of primal part of the brain that's actually triggering these inbuilt, what we call central pattern generators. They're kind of like our pre-programmed, run models. And so we start these very early run models, central pattern generators of swallowing, very, very early on, 18 weeks in utero roughly. And that swallowing, that movement of the tongue starts to drive those forces that's maintaining that tense structure. So that's pushing up on the roof of the mouth, on the palate, that's starting to push on the little early growth centers that are in this part of the cranial base there, the maxilla. We've got sort of growth centers that need pressure on them in order to be able to get the stimulus to grow. And if we've got any sort of dysfunction of swallowing in utero, whether that's an input from in terms of neurology, or whether it's a restriction in terms of things like ankyloglossia or tongue ties, what it means is that child then doesn't have those forces, doesn't have the tension in the guide ropes very, very early on.
Yeah.
So then we're born, and of course there's all sorts of other stresses that are involved with birth, as both you and I know with our kids. And so that can also cause some interference sometimes in terms of how we land some of these movements that are our inbuilt programs. And if our inbuilt programs aren't running appropriately, then we're not getting those forces and we're not maintaining that tense structure. So it's really early on that some of this dysfunction can happen, and oftentimes it's missed, as you and I know. Like it's my eldest daughter, who's now coming up 17, it was missed very early on, her oral dysfunction, and that was kind of what again drove me to figure out why isn't this working properly? Why couldn't I get her to latch well? Why was it causing so much trauma? And there's that information as to what to look for very early on is what you and I are about. Like let's get this information out there.
Yeah, yes, exactly. And that knowing the why just guides your decision making so much clearer. And that's my passion with these chats and with working with parents so early. It's like if you can see a bit of maybe the whys and highlight the red flags, then you can find the answers a bit quicker, hopefully, in a calmer, more like clear.
It has a huge effect. Like it's not just like oftentimes I'll get parents presenting with a child that they might be latching okay, like they've got efficient milk transfer, but the child is really unsettled. They might be really windy, they might be really distressed, their sleep might be out of or they might have developmentally, they might be not kind of meeting the milestones of their peers. And the parents, like that's the flag, that's where they go, oh, something's not right.
Yeah.
And they come in and we start to, when we do our assessments and we do a lot of tests around the mouth and the inside of the mouth, looking how the tongue moves, looking at how the muscles are forming. We're looking how's that child breathing? Are they breathing through their nose? Are they breathing through their mouth? What is the effort of their breathing? When we start to do some of these assessments, even though their original presentation wasn't necessarily relating to oral dysfunction, we find that the oral dysfunction has actually driven some of these other presentations. For example, if we've got a child that is not swallowing correctly, and maybe they're doing something that's known as orofacial, which, as you know, is swallowing the air, that really starts to cause some disruption to our digestive processes. And so that can present like colic. It can present like the really unsettled child that's having trouble winding. And so it might then start to drive the child. And we know this now, if we're not swallowing correctly, if we don't have that correct oral posture very early on, if we're not getting really good transfer, that can actually drive a stress response in the brain. So the child is in a heightened, like alertness, heightened stress response. And so they're very unsettled. They're not getting into really good sleep rhythms, and it starts to change their whole sleep architecture. So this is where we get, sleep disturbances and things like that, where we then get things like if we're not getting good inputs and around the mouth, the brain's not getting like the information, then what happens is that we're actually inhibiting our brain development in so many other areas. So that infant might have low tone, they might not be moving appropriately, they might not be able to hold their head up, things like that. It's actually quite a global picture. If we think about the oral structures, so the whole sort of like face, mouth in particular, it takes up a huge amount of brain real estate, like massive. It's huge. If anyone's come across what's known as the homunculus of man, we can see just how much this takes up in the hands. There's a kind of like next door neighbours in terms of like brain function. So if we, this is why I'm talking a lot with my hands. So if we notice that we've got some dysfunction globally, we will almost always have some sort of oral dysfunction as well, which may or may not have actually presented as symptomatology. And then as we try to progress on, like, I can get a child that might come in at sort of 7, 8, 9, and they've come in with like the repeated upper respiratory tract infections, the crowding of the teeth, like behavioural challenges, like all these other things. And even before I've looked at the history or asked any questions, like I know that child had a certain developmental trajectory. Like I can ask key questions that maybe the parents or caregivers haven't shared in the history. And I can go, did they actually, have trouble winding? Did they have trouble getting into good sleep cycles? Did they? And I can ask these other questions, which then traces back the origin of this dysfunction in the beginning. And it's kind of like, that saying, all roads lead back to Rome. And in my work, a lot of dysfunction actually leads back to very early oral dysfunction, even if it's presenting at 13, 14, 15. Yeah.
No, definitely. It really does. That's, and that is covering some of those red flags. Which early milestones, though, so just flipping a little bit, or daily habits give you the biggest clues about that child's oral development is on track or starting to drift off course?
Okay. All right. Well, I think probably the biggest one is how are they breathing? Are they noisy breathers? Are they breathing with their mouth open? Do they have their tongue sitting forward? Do they sound like little hedgehogs, too much? Like snuffly breathing is very normal very early on, but it actually should start to regulate around about 6 weeks. We should start to get a quieter breathing. So breathing's probably the first red flag that I would be thinking about, regardless of anything else. How they feed, and you would know this in your line of work, right, from how they latched at the beginning to how are they managing different textures, flavors, and, foods at, 10, 11, 12. Like, is there any interference to that? Is it, we should see a child go from sucking, like whether it's bottle feeding, breastfeeding, whatever is available to the caregivers, they should then have a healthy transition into chewing food. And we know this. We know that what happens is that those central pattern generators, these little inbuilt programs that we have, switch at around about 4 to 6 months, where we go from sucking being the primary form of us getting our nutrition to chewing. Chewing is really important, and it takes a little while for that to land. We've got to learn how to do it, just like we learn how to hold our head up and we learn how to crawl, we learn how to walk. We've got to learn how to chew. And if there is any kind of disruption to that, like the child's not managing a bolus of food, that's a pretty big red flag. Sounds are really important too. Again, you know this in your line of work. A child should be doing those interactive sounds really, really early on, like very, very early. Like we should be getting those babbles and coos and mimicking. Mimicking is really important. If a child's not smiling and mimicking you from sort of around about 6 weeks, that's another really big red flag. Speech is a big one. I say to parents, because they go, oh yeah, like I kind of know what they're trying to say. But what can often happen is if the tongue doesn't have really good motility and it hasn't got good coordination, the sound is really affected because they're not lifting the tongue up. They don't articulate very well, as you would know your line work. So speech is another really big red flag. And it's often missed, particularly with successive children. And they go, oh, that's because their older siblings talks for them, or, the parents have kind of figured out what the kids need, so they preempt their needs without the child necessarily communicating. And so, again, it's often overlooked. And it's like mouth open. That's another really big one. Like if we've got our mouth open the majority of the time, that's telling me that those gyrobes are not being activated. Yeah, it tells me that we've got low muscle tone. Muscles are like use it or lose it. If we don't have the tone of the muscles, we will lose muscle mass. This is why astronauts actually start to lose muscle mass. And when they lose muscle mass, they lose bone density in space. This is why I can't keep them up there for very long without gravity. We need that tension on the system to maintain the muscle mass, which then actually puts the forces on the solid structures, on the cranial structures, in order to be able to maintain the bone density. So we have a law that's known as Wolff's Law. It's that bone grows according to lines of stress. And so if we have proper tension on the system, then it's going to grow appropriately. But if we don't have proper tension on that system, that's where it caves in. So mouth open, low tone, like the dark circles under the eyes, the kind of sunken in cheeks, crowded teeth, poor speech, poor feeding. But again, it's global. Like how's that child's attention? Because if we're obligate mouth breathing, if we don't have our tongue resting on the spot, it drives our nervous system into a stress response. It limits our access to this very important reasoning part of our brain that starts to affect our attention and our focus. How's that child sleeping? If they're having trouble winding down or they're having trouble staying asleep, that's a red flag, regardless of whether or not they're snoring. If they're having difficulty coordinating their body, like if they can't coordinate their body, again, there's so much of our brain real estate's taken up by these oral structures. We actually need them in order to be able to manage some of these other things. So the reflexes that make your baby kind of grab onto your finger are the same ones that make the baby suck and lift their tongue. So if we have a child that's developed with these reflexes not landing properly or integrating properly, that might be that they're really uncoordinated. That might be that they actually have poor posture. That might be, so again, red flags. Pretty much use your parental caregiver instinct. If you kind of go, I don't think that's right. I don't think they're developing well, whether or not it's related to the mouth, that's probably something that could be looked at just to change that child's trajectory. As the twig is bent, so the tree grows, and we want to just kind of bring that twig back into line so we get that optimal developmental trajectory.
Yeah, definitely. And I'm saying a few times this week to families that just because it's common doesn't mean it's like it's typical and that it should be happening. And I think that does fall into place with speech development and, they'll get there. Or, the sleep particularly being up and down. It's okay. That's pretty common at this age. And but if in your mum gut or your parent gut is not saying something different, that's really time to listen. Find someone. Also, I want to mention again, if you comment chew, you'll gain access to the guide of why children must chew. And I think you've touched on a bunch of those areas in that, Sam, with like Wolff's Law and the reasons why we chew and why we would use the munchie to support these areas. So I think we've kind of covered all our questions. So I don't know if there's any questions in jumping into the chat. I'll just check, but I don't think so today. I'll just see. Maybe that we just, I guess, what would be your 3, I'm only going to let you have 3 key sort of red flags that you, really, really want to make sure that every parent is aware of to seek help.
Okay. Red flags, highly distressed child, regardless of age, stage, anything.
Yep.
If the child is dysregulated and having a really hard time, then that's a red flag, yeah?
Yep.
Because that's not a failure of the caregivers, that's the nervous system not adapting appropriately. Okay, so if the caregivers are giving all the right love and care and environment and inputs, but their child is still really dysregulated and unsettled, that's a red flag. That's probably my biggest red flag. The next one would be the mouth breathing. You know, if we're not breathing, if we don't have nasal patency and we're predominantly mouth breathing, that would be probably my next red flag. Oh gosh, now pick the third one. I think development. Like if you're noticing that your child's just kind of lagging a little bit, and yes, that is a spectrum, but if you notice that your child is lagging a little bit, like just not meeting milestones effectively, symmetrically, like on time with their peers and in a way that's kind of confident and rolling out, then that's probably a pretty big red flag as well. Those would be my big three.
Yeah. No, that's great. To sort of summarize, we did just have a question come through. So what is the first step in your mind for a 4-year-old with crowded teeth and sleep disruptions?
Okay. Biased because I'm a paediatric chiro, so I'd say like check in and find your local peds specific chiro, and just like everything else in the world, there's a spectrum of professional. So go by word of mouth, talk to them, have conversations, look on our Munchie directories, who's registered as a ped or my Munchie trained chiro, and definitely finding the professions in your area that will understand a little bit about this. So this is where the directory is really helpful, like coming onto the My Munchie directory and getting some help, because absolutely, like, Munchie is going to be a really good input here. Like, it's going to be amazing. And 4 is a great age. I find 4-year-olds are super compliant because it's fun. And most of them who've got some of that dysfunction are oral sensory seeking anyway. They're trying to put things in their mouth because their brain's trying to get it online. So Munchie at 4 is actually really fun. It's cool. It's great, especially if the parent does it as well, because 4-year-olds love to do hard work that the caregivers are doing. But what you might find is, because there might be some underlying dysfunction, that might not be necessarily enough. So definitely checking in with a local provider, and getting some supports with using the Munchie as well. And just be gentle with yourself, with the child. No,
definitely. So I think that's finding that directory, finding people in your area, because I think that My Munchie directory has just such a range of people you can see, and where to start is such a big question. Whether it's chiropractic, speech pathology, trained in orofacial myology, or dental airway focused dentists. So, but finding someone in your area, that's why I love that directory, because it just helps you find someone that is thinking the way you're thinking as a parent, because they're trained in My Munchie, and that will start your journey, and hopefully they're connected in your area too. There's a few more questions coming through, which is great.
Good.
Another one is it ever too late to get help with teeth crowding and mouth breathing? Is it ever too late to get help with teeth crowding and mouth breathing?
Not at all. You've kind of got to manage our expectations. You know, like if we start with an infant that's a few days old that's got a tie, and we've got a team of people that are working on the tongue tie and helping that child rehabilitate, the outcomes are going to be very different to a 65-year-old that's gone, oh my goodness, all my dysfunction, all my life is related to this, and I want to do something about it. There are so many amazing, particularly like functional dentists out there who could still provide a lot of interventions that are going to work with that. And even, again, just working with Munchie and a Munchie practitioner is going to be really helpful. You will get change. We've just got to manage our expectations around that. So I'm a good example of this. I didn't start my journey. I had terrible, horrific problems with my TMT and everything like that. And I started very late, like I was out of adolescence. So I had to manage my expectations about what my outcomes were going to be. They're not going to be like my children, who had very similar patterns, have these beautiful, big, lovely, broad arches and things now, because they had a lot of inputs very early on. I didn't have those inputs very early on. So I've managed my expectations around that. So it's never too late You know, like it's never too late to start exercise. It's never too late to start eating well. It's never too late to start looking after ourselves. We've just got to manage what our expectations are of the outcome.
Yeah, no, definitely. And yeah, so what, and he went on to say, what common age people start consults and treatments? Like in my world, and as orofacial myologist, we often say that myo doesn't start till 3. But there's so much we can do before, like from newborn, to change that trajectory, like we're talking about today. But there is also, you know, I had a consult with a 17-year-old yesterday. So it's, yeah, big range. So I don't think it's ever too late, and it's usually never too early as well.
No, I love teaching little babies to.
Yeah,
that's great.
My daughter could pop her tongue at 4 months old and hold a suction before 1. So she doesn't have the best genetics, so we have to help her from the start. Then another question around, does myomodulation help with ties and high palates?
So not myomodulation specifically, no. Like again, it's a tool. It's not something that's going to correct this. What will correct it though is if you are able to give the palate the right stimulus by, again, these gyros, the muscles, the tongue being in the right position, that will change the shape of the palate. The myomunchie is a vehicle in which to be able to do that, but it's not like the myomunchie itself is not going to change the palate. The muscles, the tongue, the tension, the gyros are going to change the palate. It's not the myomunchie itself. In terms of ties, there's 3 components to ties, and this is what I talk to caregivers about. We've got the actual physical tie, so it's often type 2 collagen fibers. It's very restrictive. It doesn't have a lot of give. It's like it's really stiff. You know, it's not necessarily going to stretch most of those fibers, and so that's a physical restriction. So there's kind of really no other inputs for that other than reducing that physical restriction. Yeah. There's also the neurology. There's the actual brain getting the messages to the tongue. Can the tongue elevate the way that it's meant to? Or not. And so that is very much something, again, if we train the tongue to elevate, which is what one of the things that, again, Munchie as a vehicle is going to bring about, then that will help with tongue elevation. It's not going to reduce the tie, but we're going to use it as an exercise tool to train the tongue to elevate. And then the other one that is, you know, as that pathway, is that habit that we have. So is there any interference to the tongue elevating? Or like, what is our habit with the tongue? So this is where myomodulation comes in, is that it's going to change the habits around our tongue elevation. It's not going to do anything to the tie itself. It's going to change your habit around how you hold your tongue. It's not necessarily going to remove any interference to the tongue elevating, but again, it's going to just help us retrain it and rehab. So hopefully that's a helpful answer.
Yeah, that's a great answer. I love that. Specific recommendations in Victoria, Melbourne. Oh, you're very lucky down there, but I would just jump on the Munchie website and check our practitioners. Victoria, Melbourne are filled.
You've got so many
amazing practitioners. Yeah. So you're not lacking down there. And the last question we might just quickly do is, do we recommend frenectomies?
Sorry, do we
recommend frenectomy?
Oh, that's a tricky one. Okay.
It's a very tricky one, yes.
So,
short and sweet, I
think. There is no gold standard. So if we're going to go, hey, we want to pull from evidence-based, there's actually none. There's none. So there's a lot of people, really clever people, doing a lot of research around this. So and this changes. It changes all the time with the more that we know. It's almost the more that we know we don't know. But what we know now is that if there is a restriction, type 2 collagen fiber that's not moving, that is inhibiting proper or optimal function. And we kind of need to do something about that. So that's kind of where we're at now, is that, do we recommend them? I don't know, because I can't take a histological study of that like frenulum and go, oh, actually that's got like muscles and nerve and blood vessels, and we probably don't want to go in there and do a frenectomy because it could potentially cause some damage to the lingual nerve. Like I don't have the histological studies to be able to do that. I don't have access to a functional MRI to see, oh, is the tongue actually elevating with like an observable type frenulum. Like I can't see that. So we've only got to do the best that we can with what we've got. My clinical approach to this is very much, again, like I say, the evidence so far shows us that if there is a physical restriction that is inhibiting proper movement of the tongue, that has quite like detrimental outcomes. Like we know this now. And so it's important for people to actually have that analysed and diagnosed. So it's outside of my scope to diagnose a tongue tie. I tell parents, I say I assess function, looking at how the child's tongue's moving.
Yeah.
And then if I find some restriction or something where I feel like that's the tongue's not moving appropriately, I'll refer out to a practitioner who can analyse, diagnose, and potentially offer a correction there. So I will often do that referral because what I've noticed from my scope of care is dysfunction and poor elevation. And so I'll send them out I'll refer them out to get that analysis, diagnosis, and appropriate treatment. And not everybody releases the frenulum. Not everyone does it. We can still get really good outcomes. I think the biggest thing I share with caregivers is I say, I can give you all of my clinical information, I can give you all my clinical knowledge, I can refer you to people who I trust, who I've seen do amazing frenectomies and have like wonderful outcomes. But the only person that's going to know what's right for your child is you.
Yeah.
Like that gut feel is you've got to trust that one. And it's okay if you think, oh my God, I'm not going to do it, I don't want to do it, it's too much, it's too invasive, I don't want to do it. And then change your mind when you get more information. That's okay too. You don't have to stoically hold on to this belief that I don't want to do it because my GP told me not to do it or my paediatrician told me not to do it or whatever. And you kind of like hold on to that even though you're getting lots and lots of evidence and your gut's telling you, no, I need to go and do something. Yeah, so I'm a human being. I read research and stuff all the time. I'm a real geek, right? But I only know what I know. I only know what's up here. Yeah. And I only have my own lived experience with my children. That's not going to be enough for a parent to make a decision. They've got to make that decision with the information that they have available to them and how that sits with them. Yeah. That was a really long answer to a short question.
No, I completely agree on what you just said, because I think everyone is individual, and every child that comes into me, I'm not for or against. It depends on the person and the timing in their life even, or if they are. But then also, I think just by being on this conversation today, frenectomy or not frenectomy, you're on the right path and you're considering that oral space, which is whether it's for yourself or your child, the person that asked the question. I think that it's like you're doing what is needed. Yeah. For that function.
Yeah, I do want to add in there that frenectomy is not a magic bullet, because you've got to think that child's been swallowing for about 18 weeks in utero.
Yeah.
And I've been swallowing with that ankyloglossia, with that tongue tie. They've developed a really abnormal behavioural pathway or habit of swallow. So this is where sometimes the people say, oh, the frenectomy didn't work. It's because they've just gone in there and released this tissue. And then what we have is an under-facilitated, hypermobile tongue. And the brain doesn't know what to do with it. So, and that's like my worst nightmare. I've seen it in the office a number of times where kids come in. Oh, we had the frenectomy done, but they still can't eat, they still can't swallow, they still can't move. I'm just going, oh my goodness. Yeah. You're like, their nervous system, their body has adapted to this tongue that's restricted. It's done the best that it can, and yeah, it's not ideal. But we haven't taken into account that whole picture of what is interfering with the brain being able to coordinate with the tongue. And we need to retrain this habit. Like, we need to retrain that neurobehavioral pathway. We can't just go in there and do a frenectomy and expect it to be better. It's not a magic bullet. Sometimes it is, because the child's nervous system adapts really well, but a lot of the time it's not.
No, and that's where orofacial myology comes in, bodywork comes in doing the prehab and the rehab.
Absolutely.
And that is outcomes. And I would I never ever see family for a release without that prehab experience.
Not at all.
So, yeah, incredible. Well, I do think that's us for today, Sam.
Yes.
We might have to jump back on for another one soon.
Oh,
yes. But a reminder, if you comment chew now, you'll get that guide to Why Children Must Chew, which is just a great resource. Pretty much every one of my clients gets it. So jump on and comment chew before we finish up, and you'll get that into your inbox. And yeah, I just want to say thank you again, even coming on unwell, Sam. And we will definitely try and do another one in the new year, I think.
I have a good
So much
voice.
we could talk about. Yeah. No, amazing. Thank you for your time. We'll see you soon.